Good morning. Thank you on behalf of our hematology service at Sloan Kettering for the opportunity to share with you our findings. So we're going to be talking about a program we've been running on enoxaparin dose reduction for thrombocytopenia in patients with cancer. And it's a quality assessment study. So thrombosis is a common complication in cancer patients, widely believed to be the second leading cause of death in cancer patients, classically treated with anticoagulation. Obviously, anticoagulation is associated with an increased risk of bleeding. In addition, from chemotherapy and other therapies, patients with cancer often become thrombocytopenic, also a risk for bleeding in cancer patients. So we've had to try to balance the need for anticoagulation and the concomitant occurrence of thrombocytopenia or low platelets, and how do we deal with the overlapping situations. And this is a very common problem in the cancer patients for which there's been pretty much no validated literature. A number of institutions about 5 to 7 years ago began to implement guidelines showing that with platelet counts over 50,000, one could maintain full dose anticoagulation. For patients whose platelet count was between 25 and 50, they recommended half dose anticoagulation, and under 25,000, they recommended holding the anticoagulant altogether. But as I emphasized, there was no prospective data that led to these guidelines, and there's been no validation of the guidelines. So when we implemented the guidelines in 2010, we followed them fairly rigorously in our institution, and this gave us the opportunity to validate both adherence and adequacy of the guidelines themselves. So we did a quality assessment, quality improvement initiative to validate the guidelines, as I said. The first question is, are the doctors at Sloan Kettering adhering to them? And second of all, are they working? Are we seeing problems with bleeding? Are we seeing problems with recurrent thrombosis? Are we seeing need for improvement? So we did a sequential catchment of cases. We had 15,000 patients during the 3-year period for whom there was active cancer and a thrombosis and were being treated with anticoagulation. And when we sequentially isolated the cases for episodes of thrombocytopenia of 7 days or more, we had 102 patients who fit the criteria and 143 episodes of the thrombocytopenia. So this gave us a nice opportunity to validate our work. As one would expect, the large majority of patients with thrombocytopenia was on the basis of chemotherapy. 79% had chemotherapy as the sole cause of thrombocytopenia. An additional 9% had mixed causes, which would be thrombocytopenia from chemotherapy plus infection or other problems. And then there were a few patients who had marrow invasion, liver disease, or other causes. We were very gratified to notice that the doctors at Sloan Kettering were adhering to the guidelines, in that in 62% of the cases, the anticoagulant was held. In 14%, the anticoagulant was reduced. In 19%, there was a mixed management with a combination of holding and temporary discontinuation, and in less than 5% of the patients did the anticoagulant remain unchanged. What was most gratifying was the fact that the outcomes were exactly as one would have hoped, in that during these periods of time of thrombocytopenia, when the anticoagulant was appropriately dose adjusted, there were no major bleeding episodes and there were no recurrent thrombosis rates. So we can't really give you statistics because there was no events. In one episode, which we refer to as the exception that proved the rule, one patient fell, hit his back, and had a retroperitoneal hematoma. That occurred on the 3rd day of his thrombocytopenic episode, prior to recognition that he was thrombocytopenic and prior to enoxaparin dose modification. So the take-home points here is our institution was following the guidelines with approximately 95% adherence, and when adhered to appropriately, we saw very gratifying safety and efficacy results. Many institutions have used similar guidelines. As I said, under 25,000 platelets typically hold the anticoagulant, 25 to 50, a 50% dose reduction, and 50,000 above that, one can maintain full dose anticoagulation. And our experience now is the first validation of those guidelines, which we think will have an important impact on practices around the country and around the world. A couple of points I think we would emphasize. One is education of the practitioners is important. Guidelines are only useful, as Dr. Crowder would say, drugs only work if the patients take them. Guidelines are only useful if the doctors pay attention to them, adhere to them. And we've published these guidelines in our internal intranet, and this is going to be shared, obviously, with others as well. We also caution against extrapolating from these results to the other anticoagulants, the new direct oral anticoagulants. The safe and effective use of those in the setting of thrombocytopenia would need to be prospectively validated. And one would acknowledge that the highest quality of data is always in a randomized clinical trial, but the nature of this kind of event of thrombocytopenia in cancer patients with thrombosis would not really lend itself to a prospective clinical trial. Thank you very much.